the famous Professor Vivian Fonseca. He's a professor of medicine, assistant dean for clinical research, and chair in diabetes and chief of the section of endocrinology in Tulane University Medical Center in New Orleans, Louisiana. He's the past president for science and medicine of the American Diabetes Association 2012. He has served on the board of directors of the American Diabetes Association and the American Association of Clinical Endocrinologists and the board of trustee of the American College of Endocrinology, and has held a leadership role and served on the various committees in several other organizations, including the American Board of Internal Medicine. He is the editor-in-chief of the Journal of Diabetes and its Complications. He was editor in the chief of Diabetes Care from 2007 to 2011, having formerly been associated editor. He was until 2006 editor-in-chief of the Journal of Metabolic Syndrome and Related Disorders. He served on the editorial board of the Journal of Clinical Endocrinology and Metabolism 2003 to 2006, and he's a hub reviewer for several other journals, including New England Journal of Medicine, The Lancet, JAMA, and Diabetes. Dr. Fonseca is a fellow of the Royal College of Physicians London and the American College of Physicians. Dr. Fonseca has served on and been chairman of the Clinical Practice Committee of the American Diabetes Association, Disaster Task Force, and ADA Strategic Planning Committee, and the Joint ADA and American College of Cardiology Make the Link program. He has played a significant role in developing guidelines for diabetes, the ADA and the AACE, managing chronic diseases and clinical trials after a natural disaster, and drawing attention to the global epidemic of diabetes, particularly in Asia. The American Diabetes Association awarded him the ADA Banting Medal for Leadership and Service, and the Southern Medical Association awarded him the Steele Harris Award. The ADA presented Vivian Fonseca Award annually for research on diabetes in Asia. He was received several teaching awards and was elected to the Alpha Omega Alpha Honor Medical Society, and has been listed for several years among the best doctors in the United States, Louisiana. Dr. Fonseca research interests include the prevention, treatment of diabetes complication, risk factor reduction in cardiovascular disease, particularly on the role of inflammation and other novel risk factors. He has a research program evaluating inflammation in diabetes and using technology to improve diabetes care in unprivileged populations. He has been an investigator in several National Institute of Health and Industry funded clinical trials, including the very famous Action to Control Cardiovascular Risk in Diabetes, all diabetologists know, the ACCORD trial, and TINSAL 2D trial. He is a co-principal investigator of REACH Consortium funded by PCORI and serves on the PCORNET clinical trial task force, and is investigator in several current trials, including National Institute of Health funded PACT2 and all of the United States studies. He serves on several steering and ancillary study committees and data safety monitoring. Dr. Fonseca has a strong interest in facilitating clinical research and development the next generation of translation researchers. He is the Director of Professional Development Corps and Associate Director of Clinical Research Resources for the Louisiana Clinical and Translational Science Center. Dr. Fonseca has lectured in the United States and abroad. He has published over 400 papers and articles. He is the editor of the textbook, Clinical Diabetes, Translating Research into Practice by Elsevier. He has several monographs and book chapters. Welcome you, Professor Fonseca. We hope
very much,
next time to be in Cairo. Your topic today will be new updates for diabetes management. Professor Fonseca.
Thank you very much, Ibrahim. Thank you to Eva for inviting me and giving me this opportunity to talk to all of you today. I remember I have very good memories of my visit to Egypt a few years ago. I visited Cairo, Alexandria, and actually spent a few amazing days in Luxor, admiring the history. And being born in India and growing up there, I'm very conscious of ancient cultures and how this developed, and the things that we respect today that have come down the centuries from what was found by our ancestors before. So I'm very pleased to be talking to you today. Of course, we are living under very challenging circumstances. You see my mask. I'm fortunate that we have Zoom and we don't need to do this with a mask. I'm very connected with you through this modern technology. So I'm going to share with you today some concepts of endocrinology diabetes that have come into play and changed how we are practicing diabetes very much. And as I mentioned, we cannot ignore things like the COVID infection. And at the end, I will touch a little bit about how diabetes is interacting with COVID. So let me start. I'll first of all pull up my, share my screen and pull up my slides. So I hope you can see the slides okay. And let me move this a little bit. Okay. So I'm going to talk about new issues about diabetes management today, and some things haven't changed. The most important thing that hasn't changed is that diabetes is a very complex multifactorial disease. My colleague and good friend Ralph DeFronzo, in his Benting lecture a few years ago at the ADA, talked about the ominous octet. Today, he recognizes, along with many of us, that there are more than 8 abnormalities in diabetes. And we often need to adapt what we are doing with our patients to recognize which one is the dominant player and make adjustments in people's treatment accordingly. These 8 are important because we have treatments to address them. Yet we have a challenge in not being able to give every patient 8 medications. No patient will accept that. So we have to find the right treatment for the right patient, what we are calling personalized medicine, and something we are working on today. And I'll come back to that in terms of choosing based on what's happening with the patient, the right medication. If your patient has heart failure, for example, or chronic kidney disease, or is free of these diseases, yet you want good glycemic control, or you need weight loss in some people. So all these abnormalities give us opportunities to practice the art of medicine and choosing the right treatment for people. Our aim remains to control diabetes well. We know from old studies like the UK PDS that good glycemic control matters. An A1C reduction of 1% leads to 21% reduction in death, 37% reduction in microvascular complications. Less impressive on heart attacks, and I'll come back to that. But it's also important for amputations, strokes, etc. And today, as we think about COVID at the end, we'll come back to the fact that many of our severely ill patients with COVID infection have very poorly controlled diabetes. So controlling diabetes might actually prevent people who get exposed to infection from it becoming too severe and affecting them. Now, one of the problems we have with diabetes is that it keeps progressing. The beta cell failure keeps getting worse. And we start off with monotherapy, and when that fails, usually after 3-4 years, we add on the second therapy, and then after a few years, that fails. And then we keep adding therapies, but we do it in a very haphazard kind of way, waiting for failure and having failure for many years. And we need to be more proactive. Get the A1C down, keep it down, recognize when things are not going right, and not waiting for failure to be perpetuated. So there are also a few common things in most people with diabetes. They have obesity underlying it, insulin resistance, obesity, metabolic syndrome, with dyslipidemia and hypertension. And together, these drive a lot of the complications of diabetes, particularly cardiovascular disease, but also chronic kidney disease. So when we are choosing glucose lowering, we need to choose the appropriate one for the patients, because we have learned from the many long-term cardiovascular outcome trials that have been done that how you lower glucose makes a difference. It's not just a simple matter of lowering glucose. You got to choose the right treatment to get the best outcomes. And we are very excited today to have so many new medications. And I don't have time today to talk about all of them. I'm going to focus on one or two, and of these, I was very pleased to hear that this is a launch day today for empagliflozin monotherapy in Egypt. So let me just point out a trial for you that is very important, the EMPA-REG Mono. I want to tell you about a study that was published a few years ago in the Lancet, which compared not just empagliflozin with placebo, which is what we often see in clinical trial publications. And there's nothing wrong with comparing with placebo because it helps us understand medications, but making a comparison with another commonly used medication is also important because in practice, we don't choose placebo. We have to choose between two different drugs. What is the better one for a patient? So this trial actually does both things. In fact, it does three things. It compares empagliflozin with placebo and 2 doses of empagliflozin with placebo. It also compares it against 100 milligrams of sitagliptin. And this is for patients with A1C of 7 to 10%. And it does a third thing of people who start off with A1C very high to see how they would do with a full dose of empagliflozin in an open label manner. So let's look at the results. Firstly, you see on the left-hand side that sitagliptin worked as expected. In fact, it worked a little better than in the sitagliptin trials in that it lowered A1C by 1%, which we haven't seen in many trials with sitagliptin. And empagliflozin lowered A1C by about 1.4% in both doses. And the placebo group really had no change in A1C. So it was statistically significantly better than placebo. And starting from a baseline of about 9%. On the right-hand side, you see what happened in people who started with a very high A1C. They were chosen because they were above 10. In fact, they were above 11%, and they dropped by 3.7%. And you often see this with SGLT2 inhibitors. They already have glycosuria. And by lowering the glucose threshold, you give them even more glycosuria, and they are able to drop their A1C very, very substantially. Now, I just want to caution you, they got down to a little below 8. We want them lower. And we need to recognize among these very severely ill patients who needs monotherapy and who could possibly start with combination therapy, even maybe combination with insulin in some people because they're very severely deficient. So we need to look at that population very carefully. And some people will do well with monotherapy. Others may need combination therapy as in the ACE guideline. Even so, the monotherapy group with empagliflozin across the board in this trial did very well with lowering A1C compared to sitagliptin or placebo. But they had an added advantage. It lowered empagliflozin in both doses, lowered body weight, whereas that did not happen in the people who were treated with sitagliptin or placebo. And in the people who had very poor control, there was actually a small gain in body weight because these people were very catabolic before, and now you reduce that catabolic effect. Now, if you look across the various phase 3 program with empagliflozin, you see that there's a reduction in body weight. It's not huge. You wouldn't call this a weight loss drug, which is only 1 or 2 kilograms in many patients needing more than that in weight loss. But one important thing to remember is that it occurs in almost everybody. It's a consistent drop in body weight as compared to GLP-1 receptor agonists, where you can get a lot of weight loss in some people, but not in all. It's not consistent. Here, almost everybody will lose some weight because of the very mechanism of action of losing calories in the urine. So you can more or less guarantee that you will lose weight when you treat somebody with empagliflozin. Here's the another important feature of SGLT2 inhibition, and here you see in the EMPA-REG Mono trial a reduction in blood pressure. Reduction by about 4 to 5 millimeters of mercury, which is not trivial because sometimes it's challenging to get patients with diabetes to have good blood pressure control. So you're able to do that, which is, I think, a very important finding. It helps in relation to the cardiovascular disease as well as the chronic kidney disease and proteinuria, which I will come to later on. But just in general, improving blood pressure is very, very important. So this happens with systolic and diastolic and is very consistent across all the trials. And here you see the data from the other trials in combination. You see 3, 4, almost 5 millimeters of mercury reduction in blood pressure, despite the fact that many of these people were having background antihypertensive therapy. So reduction in blood pressure, we know, is very good for people with diabetes. And this further reduction with this drug is going to be very impactful on long-term complications. Now, we talked there about empagliflozin monotherapy. Many people still strongly believe and support the concept that metformin is should be the first-line therapy for diabetes. We still debate now whether it's time for us to consider other drugs. In fact, I think in some situations, maybe metformin should not be the first line, because now we are having data on patients with congestive heart failure without diabetes doing better with SGLT2 inhibitors. And maybe if they get diabetes, that should be their first line therapy. But for most people with diabetes, metformin will remain an important therapy. And many people have already started with metformin, or some people with very high A1C, like I pointed out, they need 2 drugs. And if you're following the ACE guideline and you want to use 2 drugs, why not use 2 that have been tested very well, such as empagliflozin and metformin in combination? So here is a combination therapy, and I was pleased to hear earlier that this is now has been available to you from Eva for some time. So let's look at the data. Here again, the trial was done in 2 sets of patients, mainly in people with A1C 7 to 10%, and a few who came in with an A1C greater than 10. And the comparison in the main trial was monotherapy of empagliflozin, or monotherapy of 2 doses of metformin, or combination therapy in various dose combinations. And what you see is what has become very well known in the last 20 years in diabetes, where combination therapy always does better than monotherapy. Initially, we used to try to switch people from one monotherapy to another, and then we recognized many years ago that combination therapy is important because it addresses the underlying features of diabetes, addressing more than one abnormality of the ominous octet. So here is the group of people who had very poor diabetes control at baseline, greater than 11%. And here the results were even better than with monotherapy. You got almost 5% reduction. In fact, it looks almost miraculous that people with an A1C of almost 11.5 come down below 7%. A very spectacular result in people who are probably very insulin deficient at the beginning. So here are the overall results. In terms of body weight, metformin doesn't cause much weight loss on its own, but in combination with another drug, you get an enhanced effect. So you get a reduction of body weight that's more than empagliflozin monotherapy, and certainly more than metformin alone. So just for treating diabetes, you have a consideration of choosing empagliflozin as monotherapy for appropriate patients, or if you need to use metformin, or you like to use metformin, using empagliflozin in combination with metformin, and you can get very good glycemic control. I hope that you would choose that as a combination so that your patients just don't get the heart disease, and because you have achieved such good glycemic control. However, there'll be some people who are not well controlled and they have predominant lipid and blood pressure problems or genetic problems, and they get heart disease or chronic kidney disease. And there you have to consider data from clinical trials that emphasize the importance of SGLT2 inhibition as the appropriate drug therapy. And this is in people with CVD or CKD. So today, because we are picking up people earlier and that have been doing so for the last 10 or 15 years, we are going away from the concept that everybody with diabetes has heart disease. In fact, there are a lot of people out there who have no CKD and no CVD. Their diabetes is picked up very early. This is in the United States. I'm aware, at least, I don't know what it is in Egypt. Perhaps we can discuss it later on. I know that in many parts of Asia, like India, there's a lot of heart disease and CKD in people who don't even know they have diabetes, and that's very tragic. In the US, there's a lot of people whom we know don't have CKD and don't have CVD, and we should strive to keep them that way. But we still have a number of people who have either got CVD alone or CVD and CKD together, which is a very dangerous combination, or CKD and they don't know they have CVD, but they probably have that underlying. So we need to look at what can be done in those extremely high-risk patients. We previously tried controlling the diabetes very well. These are studies like the ACCORD trial and the ADVANCE and VADT, and we had no major effect on CVD. We reduced microvascular complications. We did not reduce CVD very much in people with established disease and long-standing CVD. We didn't change mortality very much. It went up, in fact, in the ACCORD trial. In the UK PDS with newly diagnosed diabetes, glycemic control was very good at preventing CVD and mortality. And the same with the DCCT. The reason for that is this concept of metabolic memory and glycemic legacy. UK PDS took people very early in their diabetes, newly diagnosed, controlled them well, and kept them well controlled. That's what we should be doing for our patients. In VADT and ACCORD, people had 10, 15 years of poor control and established complications that are impossible to reverse. So we got a different result. So that's why we get different results on just glycemic control. But now we have other ways of approaching the problem. And we are very fortunate to have many, many FDA-mandated clinical trials in a whole range of diabetes medications. SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors. Almost 200,000 patients have been entered into these randomized clinical trials, giving us a large amount of data. These were all placebo-controlled, although we are now beginning to see some active control trials, such as Carolina, but most of these are placebo-controlled. Now, some of the early trials were disappointing to some people in that they showed no benefit on cardiovascular outcomes, but these were designed to be safety trials, and they were of short duration. But now we start seeing trials that are showing protection from cardiovascular disease. And that depends on what kind of people you include in the trial. So the first of these was actually the EMPA-REG outcome trial, where you had a significant reduction in MACE, or major adverse cardiovascular outcomes, as well as hospitalization for heart failure and mortality. And you also see this to a lesser extent in trials such as CANVAS with canagliflozin, and also with dapagliflozin in the DECLARE study. Now, it appears that these other two are a little less impressive in their outcome than EMPA-REG's results, but the populations are different. In DECLARE and CANVAS, they took people a little earlier with less established cardiovascular disease, whereas EMPA-REG was done in people with established cardiovascular disease, where you got the most impressive result. Not only was there a reduction in MACE, which was the primary outcome, there was this very impressive, very surprising reduction in hospitalization for heart failure. And there's been a lot of speculation as to why this is the case. It may be because it is related to a reduction in blood pressure, as I pointed out. There's also loss of fluid, loss of volume, loss of salt in the urine. So many reasons why these drugs could help heart failure. And I think that's more or less widely accepted now, and it's across the board for this class, and many mechanisms that are understood. So just to reiterate some features of the EMPA-REG outcome trial, this was a global study done across the world, very wide population, including people in Asia, Africa, and Australia. Patients with known heart disease were randomized to placebo and 2 doses of empagliflozin and followed up for a median of 3 years. And the primary outcome, as I pointed out earlier, was a composite of heart attack, stroke, and death, what's called MACE, 3-point MACE. And that was reduced 14%, which was statistically significant. But for the first time, we saw a reduction in cardiovascular death of 38%, which is very impressive. Reducing mortality is what we want to do in clinical practice. So this was an important result. All-cause mortality, cardiovascular mortality, both were reduced. I'm not going to go into every little outcome there, but apart from this MACE outcome, as I pointed out, there was reduction in hospitalization for heart failure. And they also noted some renal protection, which I'll talk about in more detail. This was important. We were seeing in patients already treated with statins, benefits on the heart, and on RAS blockers, benefits on the kidney. So secondary prevention as well as primary prevention of some of these features. Now, the heart failure concern is very important in people with diabetes, and a lot of people with diabetes have heart failure. So finding a drug that will improve the outcome of this heart failure is very important. So here is the heart failure result in EMPA-REG, 35% reduction. And it didn't matter whether you had previous heart failure or previous cardiovascular events, you had this benefit. And there are ongoing studies now comparing people with reduced ejection fraction, preserved ejection fraction, and we will see what these results show. They are due to be completed this year, and we look forward to those results. But some people may be thinking, well, this is compared to placebo. What happens in real life and outside the clinical trial settings? So we start looking at what is called real-world evidence to complement these randomized clinical trials. And there's a study called EMPRISE, which is looking at real-world data from claims data from insurance databases from Medicare in the US. So you have large number of people in these trials. So this study is looking at people retrospectively 5 years of data over 2014 to 2019 who were treated with either empagliflozin or a DPP-4 inhibitor. And the study will be completed in November next year. However, an interim analysis has just been published in Endocrinology, Diabetes, and Metabolism with a very interesting study. And the endpoints they looked at here were multiple things on effectiveness, on MACE, on mortality, etc., on end-stage renal disease, on safety, including common side effects as well as rarer side effects, and on resources, utilization for hospitalization, outpatient visits, costs, etc. So the first interim analysis only looked at a smaller group of patients who have completed 5 years of treatment of these two classes of drugs, only 35,000 patients, but that too is a lot more than with clinical trials. And it showed very similar results as the clinical trials. A reduction of hospitalization for heart failure by 51%, being very specific, or a broad definition of hospitalization for heart failure by 44%. In people with or without a cardiovascular history, you got a reduction. So even in people who did not have cardiovascular disease, you found this outcome. The outcome is actually not very different from what we saw in the EMPA-REG trial. So it tells us that in the real world, in clinical practice, we can get similar results, and This is not against placebo. This is against DPP-4 inhibitors, where we would probably today not choose to use a DPP-4 inhibitor in somebody who has overt heart failure. You would probably use an drug like empagliflozin. But that was not the case 5 years ago. So we have this data now on 5-year data. So it's well established that empagliflozin was particularly good at reducing mortality and reducing hospitalization for heart failure, as well as reduction in 3-point MACE. Let me turn to another important finding, and that is benefits on end-stage renal disease and renal outcomes. Now, in EMPA-REG, they did look at it, but they chose an unusual endpoint for renal disease, either doubling of creatinine or end-stage renal disease or death. And they saw a reduction, but that's not a typical endpoint. And they then went on to look at end-stage renal disease or renal death, and the numbers there were very small. And they did a similar thing in the CANVAS trial and saw a similar trend of a reduction in doubling of creatinine or end-stage renal disease or renal death. So with canagliflozin, a study has been completed called Credence, and there the primary endpoint was a more solid renal endpoint, and there too they see a significant reduction in the progression of chronic renal disease. And studies with the other SGLT2 inhibitors are ongoing. So here is the EMPA-REG progression of kidney disease. New onset or worsening nephropathy was reduced by 39% with empagliflozin. And new onset of macroalbuminuria in patients who may have had microalbuminuria before was reduced by 38%. If you look at doubling of creatinine in those who had a somewhat low creatinine GFR at the start, there too there was a 44% reduction. So this is an interesting finding that needs confirmation, and it's being done. So here's the hard outcomes, and now there's a further analysis being done and further studies on SGLT2 inhibitors in patients with CKD. And the FDA feels this is very important. They feel that they should give it fast track designation for the empagliflozin to reduce the risk of kidney disease progression and cardiovascular death in people with chronic kidney disease. This is because in people with chronic kidney disease, they mainly die of progression of the kidney disease or cardiovascular disease. And there are very few additional treatment options. These people are already treated with ACE inhibitors or ARBs, and many of them continue to progress and need dialysis, which is a very complex treatment. So the trial that is being done is called EMPA-Kidney. It's a multi-center, double-blind, placebo-controlled trial looking at kidney disease progression and cardiovascular mortality in people with chronic kidney disease, whether they have diabetes or don't. And it's got 6,000 patients on top of RAS blockade. So it will be interesting to see the result. I don't have time to go into mechanisms. I just want to point out that many mechanisms have been looked at in terms of SGLT2 inhibitors. Why are they benefiting the heart? They have anti-inflammatory effects. They have blood pressure lowering effects. They reduce body weight. So they switch from utilization of glucose in the heart to utilization of ketones. Many little things like that, but together might contribute to these wonderful benefits. This is changing how we practice medicine. When you look at the evolution of diabetes treatments, heart attacks and strokes are so important. CVD is the leading contributor to morbidity and mortality, and chronic kidney disease impacts it very seriously. So now we have these outcome studies that I just talked to you about. And this is really driving how we change our clinical practice guidelines. So here's a range of various clinical practice guidelines over the last 5 years from organizations like Diabetes Canada, the ADA, EASD, ACE, and so on. And in 2018, the ADA said that you should consider when you have a patient with diabetes, whether they have cardiovascular disease or not. And if they have cardiovascular disease, which one is it? Is it atherosclerosis or is it heart failure? If you have atherosclerosis, you can use either GLP-1 or SGLT2 inhibitor, but maybe consider GLP-1 more. If you have heart failure predominant, then SGLT2 inhibitors may be appropriate, although you can use both of them. And they put in a few caveats, particularly about chronic kidney disease, and did mention that SGLT2 inhibitors may be better for people with chronic kidney disease. These guidelines keep getting updated. Every few months, new clinical trial data comes out, and the ADA now updates its guidelines on a regular basis online. So they don't wait for next year, they do it immediately. And they've added information of considering empagliflozin to reduce mortality initially based on EMPA-REG. And then they've added in information about chronic kidney disease and other kidney benefits, etc. So the guideline looks very complicated. I don't have time to go into every little detail, but if you know this very well, you've seen it, there are multiple things that you need to consider. But the first question is, does your patient have heart disease or chronic kidney disease or heart failure? And then you choose between these drugs. And here, particularly if they have heart failure or chronic kidney disease as the predominant factor, the preferred drug class is SGLT2 inhibitors. And because of the data I showed you, empagliflozin has been mentioned in many of these guidelines. So just to reiterate, SGLT2 inhibitors with demonstrated cardiovascular disease benefit are recommended as part of the glucose lowering regimen, independent of A1C. You should consider using that. So even if you have somebody who's very well controlled, say you have an A1C of 6.9, you can add it in. You should also consider GLP-1 receptor agonists in some of these people. The ACE guidelines also mentioned this. I was a part of the writing committee for this guideline, and both GLP-1 receptor agonists and SGLT2 inhibitors are right at the top in considering monotherapy, dual therapy, and triple therapy. The strongest guideline actually comes from the European Society of Cardiology, where very early in 2019, they recommended that empagliflozin should be given to people with type 2 diabetes and cardiovascular disease to reduce the risk of death. They mentioned that the class, and particularly empagliflozin, is recommended to reduce the risk of hospitalization for heart failure in people with a GFR more than 30. And now they have said that in people with chronic kidney disease, you should give an SGLT2 inhibitor to reduce progression of chronic kidney disease. Subsequently, the ACC and AHA also changed their guideline and recommended initiating an SGLT2 inhibitor or GLP-1 receptor agonist to reduce cardiovascular risk. So this is driving clinical practice. This is changing how we manage our patients, giving them a more personalized approach. We were making a lot of strides, making a lot of progress, and then suddenly we get hit with a new problem, which is COVID-19. So let me spend a few minutes talking about this. You know the signs and symptoms very well: fever with sore throat, cough, but breathlessness is a key feature over there. People get pneumonia, and the experience from Wuhan describes very well the incubation period of a few days, and then rapid deterioration in some people, and the need to reduce transmission. Now, if you look at comorbidities in this population, endocrine disorders are present in Wuhan of 13%. We are actually seeing much, much more in the United States because we have a lot more diabetes and obesity. And diabetes has been described in various trials as being somewhere between 10 to 20% of the population in various groups in Wuhan. When you look at those with pneumonia, age also starts becoming a factor. And in fact, in the US and Italy, age has been a very important factor. Predictors of mortality include people who have respiratory disease as an underlying factor, which is not surprising. In the US, we are seeing it in people who have underlying uncontrolled diabetes. Here's one study looking at the fact that blood glucose was elevated in a large percentage of patients, and glucose levels were predictors of mortality. This is in SARS. This is published a few years ago. COVID should be very similar because it's a SARS-like virus. Here's the experience in Italy, where you see a lot of elderly people affected, much more than in China. Maybe the Italian population is older and more susceptible to this kind of infection. And in Italy, 35% of people had diabetes. So it's emerging as a very important factor. And I think this is the same in the US. Not only diabetes is high, but it's uncontrolled diabetes is a problem. And in our population, in the African American population, we are seeing a lot of obesity as an underlying feature for severity of COVID needing ventilation. So hypertension, chronic kidney disease, obesity, and poorly controlled diabetes. And in fact, the ADA have put into their guidelines very rapidly, added on emphasizing management of hypoglycemia in patients with COVID-19. The standards of care remain the same for people who are in ICU for other conditions. So very often we need insulin infusions, but you need to avoid hypoglycemia, keeping the blood glucose at a target of about 140 or above. 140 to 200 may be appropriate, avoiding hypoglycemia. Very often that requires the use of very carefully titrated insulin and maybe using basal bolus regimens. Now, one of the questions that comes up, how do you monitor these very sick people in ICUs? And the question has come up, should we be using continuous glucose monitoring, either using the subcutaneous one or the patch with the Abbott Freestyle or the Dexcom or Medtronic devices? And there is no data. There's no clinical trials. It is currently not approved by the FDA for inpatient use. However, as a community, we took the decision that even if not approved, we have to look after very sick people, and to be sticking their finger every 1 hour to get blood samples is too challenging. So we are using a fair amount of CGM. And here is some data that is available from non-ICU patients in hospital using CGM, and it correlates reasonably well. It's not perfect, particularly in unstable patients, but it can help us. And this is the same is true of Freestyle Libre flash glucose monitoring. So you can get some idea of what the glucose is if you use these devices. Outcomes are poor in people with uncontrolled diabetes, so we should strive to control them very well using CGM very cautiously. So I'm going to stop there and be happy to take questions.
Thank you, Professor Fonseca, for your elegant presentation. We now have a lot of questions.
Okay.
Actually, I would like to know that you already showed that we have more than 527 participants.
Oh my God.
In this meeting.
So we'll take a few. Why don't you pick some key?
Yeah. Only the participants, not all the questions.
We'll have to come back. We'll have to come back. And when the COVID is all over, I'll have to come and visit you to answer 500 of those.
Yes. We are waiting for you next year in Cairo. First of all, so I had actually the benefit of empagliflozin treatment of heart failure. So we have 3 questions about this. First of all, how can we predict or the predictors of heart failure in patients with type 2 diabetes?
So that is a very, very good question that we are really struggling to answer. There are a few things that point to it. I want to emphasize to everybody needs to understand that this is an unexpected finding in EMPA-REG. So at the beginning of the study, they did not do a full evaluation of heart failure. They didn't do echoes in everybody. So it's best based on history, whether they knew they had heart failure or not. So how do you predict somebody's hospitalization? We are trying to do this in prospective studies now. And sometimes you can do echoes, but echoes are very, and look for HFpEF, but we don't know whether HFpEF patients benefit. If you have reduced ejection fraction, that is a confirmation that you got heart failure, but it's too expensive to do it in everybody. So we won't make that recommendation. Some people are beginning to do testing with NT-proBNP. So if you have a proBNP greater than 100, so more than 300 is diagnostic, more than 100 gives you a suggestion that it's not perfectly normal. And if you have more than 50 maybe, or maybe more than 100 with obesity and hypertension, that is predictive. Now, you can also predict it on the basis if somebody has known coronary artery disease. You have a previous MI, your risk of heart failure is higher. You could also predict it on the basis that patient may have cardiomyopathy if they also have retinopathy and nephropathy. So those are patients at higher risk. So as of right now, if I know that a patient has CKD and retinopathy or something, they got microvascular disease, and even if they don't have heart disease, I'm doing NT-proBNP and watching those who have a slight elevation, such as over 100, very carefully and considering the use of SGLT2 inhibitors. But this is by no means an official recommendation. It's just a pragmatic approach.
So can we use empagliflozin in the treatment of non-diabetic heart failure till now or not yet?
Well, dapagliflozin completed a trial called DAPA-HF, and they got an indication to use it for heart failure. There were a significant number of people without diabetes in that trial. So cardiologists are using it. The empagliflozin trial is ongoing, and we should have results pretty soon. There too, there are patients without diabetes, so you may be able to assess that. But it's interesting to know, we really need to know whether it helps patients with preserved ejection fraction, because there is no treatment right now that helps preserve ejection fraction. Maybe spironolactone a little bit, but we really don't know enough about that. So for reduced ejection fraction, I think it is okay to use it. The comparisons have been against placebo. We don't know whether you could compare it with Entresto. Maybe that's an interesting question. Entresto is not cheap. It's not easy to use. It's not widely available, but certainly you have to weigh using one or the other, or maybe should we be using both together, but that's an expensive combination.
In the context of renal protection of empagliflozin, which is preferable to decide who will benefit from it? Either cases with starting to increase in albumin to creatinine ratio, or cases with starting reduction in estimated GFR?
I think albumin creatinine ratio, if it is on the high side, is a very good predictor, because those were the patients selected in the Credence trial. They were selected based on the fact that they had a proteinuria more than 300. If you got more than 300 as the ratio, I think it really makes sense, because we know you reduce proteinuria. Then the secondary thing is eGFR. If you got an eGFR of 75, 80, it will take a long time for that patient to have a renal failure. On the other hand, if you have an eGFR of 55 and you have proteinuria of 300, that patient is at very high risk. So such patients I would certainly choose for treatment.
So, and without fear of dehydration?
You can get some dehydration in some patients, and there's transient worsening in some people. So I warn patients about it. I reduce the dose of diuretic, maybe reduce the dose of RAS blockade if they have low blood pressure. It all depends on their clinical status and their blood pressure. If you got a high blood pressure, there's no risk. But if you have a low blood pressure, then there is some risk of dehydration.
A lot of question about what's the best combination in your opinion. after metformin, we can add IMPA plus pioglitazone or IMPA plus DP4 inhibitor?
I think it depends on the clinical features and what is the patient. So, I get back to what I said early in my talk. We need to have personalized care. Let me give you some specific answers. If you have a patient who is elderly, living alone, eats erratically and is at risk of hypoglycemia and doesn't have very severe A1C elevation, I would choose a DPP4 inhibitor in combination with them. You're not going to get a big reduction in A1C, but you want to have the least side effects and you want your patient to be comfortable, not have hypoglycemia, not have many side effects. On the other hand, if you have somebody who's got cerebrovascular disease, has a previous stroke or carotid bruit, there's data with pioglitazone showing a benefit. If you have a patient with NASH, you may want to use pioglitazone. So I choose it on that basis. If somebody has a lot of central obesity with high triglyceride, I choose pioglitazone. On the other hand, if your patient has had previous fracture, I would not use pioglitazone. So it's become very complex. Choosing the right medication has become an art again. And it's the art of medicine. It's what we do in many things in our practices. You have to be an artist.
We'll come to the doses. Is there a difference between the doses of 10 milligrams and 25? This is the first question.
There is a small difference, but it's actually quite small. So I don't feel bad about starting 10 milligrams in most patients. I reserve the higher dose. Let me put it this way. The benefit on glucose lowering is actually small. There may be greater benefit in terms of lowering blood pressure and improving outcomes for heart failure that are maybe very important in individual patients. And there I will go to the full dose.
About if we're going to use it in patients with heart failure or stage 2 or 3 in CKD, what dose will start?
I always start with 10 milligrams because those are high risk patients. They might get a drop in blood pressure that they may not be able to tolerate. You want to avoid in older people as well, them getting too much of a drop in blood pressure and having a fall.
Sometimes you ask about combination of IMPA and metformin. Use it before the meal or after the meal?
Metformin is at meal time is the recommendation for metformin. It doesn't specifically have to be before or after, but around meal times is useful.
Okay. In the era of COVID-19, a lot of questions about the debate of use of oral hypoglycemic medication in patients with COVID-19. You have to stop the oral medication or continue. In patients with mild hyperglycemia.
In a patient who is not in ICU with mild hypoglycemia, I will carry on the oral agents. If they are well controlled or not too badly controlled, I think it is okay. Adding in insulin in those people are not going to give you huge benefits and is a lot of trouble with monitoring. On the other hand, if a patient is on a ventilator, there is no choice. You have to give insulin.
So you're not afraid of hypoperfusion or dehydration?
In people who have mild disease and mild hypoglycemia, we encourage them to have plenty of fluids. So we're giving those in hospital, we're giving them fluids anyway to avoid because they have high fever.
Very interesting question. Why we didn't use SGLT1 inhibitors? And is there any about the combination of SGLT1 and SGLT2 inhibitors?
We have actually done trials on SGLT. There's a drug called fluorescein, which was the first one in the class. It is a very potent SGLT1 inhibitor as well as SGLT2 inhibitor, and it caused a lot of GI side effects because of its effect on SGLT1. There is another one called sotagliflozin, which has going through clinical trials. It has milder SGLT1 inhibition. It does affect postprandial glucose a little bit better because it affects glucose absorption in the gut. but whether that is enough to make a clinical difference or not is unclear right now. Bear in mind that some of these drugs, like canagliflozin, also seem to have a little bit of SGLT1 inhibition, but it's not totally clear.
Can we use empagliflozin with any type of diuretics?
Oh yes, they're used with diuretics all the time. But you need to bear in mind that if you have low blood pressure or dehydration, it might get worse. So you need to watch out for that.
What about SGLT2 and diabetic ketoacidosis? Is it common?
It's not common, but it does occur. And it occurs most commonly in people who are actually type 1 or very severely insulin deficient. So if somebody has very high A1C, you need to first of all make sure they don't have type 1 diabetes and then monitor them for ketones very closely.
So the common question.
In type 1, we measure beta hydroxybutyrate.
Do you know about the usage of SGLT2 and type 1 diabetes?
Well, there are many studies that are published, but almost all patients get a rise in beta hydroxybutyrate. So the FDA is very cautious. They have not approved it. It is approved in Europe, but it's not approved in the US. Having said that, we do use it off label in some patients. We warn them about it. We ask them to check their ketones frequently and make sure that they are appropriately treated.
Someone is asking about is the relation between hemoglobin A1C and AC2 receptors?
I don't know about A1C, but AC2 is present in the pancreas. So that raises some interesting questions about the relationship with diabetes.
A lot of data about that AC2 is already increased in diabetics in comparison to normal population.
Yes, but that may be related to the fact that because of the thing that's going on in the pancreas, it's trying to upregulate, and it upregulates everywhere in the body.
So there is a problem with use of ACE and ARBs in treatment of hypertension in diabetics?
That's a very good question. And we've looked at our own data in our hospital. We have a lot of COVID out here, very severe cases. And we do not find a relationship between severity and ACE or ARB use. It has been reported in Wuhan. It has been reported in Italy, but we are not totally sure. The American Heart Association came out with a statement saying that if you need an ACE or ARB, you should not stop it because of this fear.
So the recommendation till now, don't stop your medication.
That's right.
Yes.
There is an editorial about it in the New England Journal of Medicine as well.
What about the usage of empagliflozin in patients with chronic liver disease or NAFLD?
There is some evidence that you reduce liver fat. That's because of weight loss. So any weight loss will remove some fat in the liver. Whether it will make a difference long-term to NASH, which is the inflammation component, we don't know. The only drug shown to reduce inflammation and reduce NASH is actually pioglitazone.
Okay. There is a very tricky question. Is there a difference between various drugs within the same group?
So, the only way to answer that question is to do appropriate head-to-head studies. To me, it looks like in terms of glucose lowering, there is no difference. They all lower glucose. When you look at blood pressure lowering, there is no difference. So is there some other magical effects of these drugs that we don't know about that will make a difference? I don't know. There are results of the clinical trials for cardiovascular disease that are different, but from a trialist perspective, these trials were done in different patient populations. You really can't answer that question accurately. So I think you need to go by what kind of patient you have and choose accordingly.
Okay.
In the US particularly, we are not making that distinction even based on The choice is usually which one will your insurance pay for?
In patient with peripheral arterial disease, there is a problem usage of SGLT2 inhibitors?
Well, there have been more reports of amputations in patients in the early trials with canagliflozin, which is probably in some ways in the high doses, very powerful effect. And the hematocrit goes up a little bit. So if you have peripheral vascular disease and already got a foot ulcer, you might have more amputation. In the subsequent trials, they very carefully managed the foot disease, and they did not have many people with overt peripheral vascular disease, and so did not have excess amputation. So the answer to that is we don't really know for sure, but if you are a good practical doctor practicing the art of medicine, you will be very cautious or not use it in somebody who has peripheral vascular disease.
Yes. Actually, we have still a lot of questions, but I think it is enough for you. We already had exhausting you for this 1.5 hours. Thank you very much, Professor Fonseca, for your elegant presentation.
I thank you for your very good. Yeah, I thank you for your very good coordination of this, and want to thank Eva for organizing this.
Okay.
Thank you very much. Thank you, Mina. Thank you, Dr. Riyad, for your very nice day. We have already more than 527 participants, which was elegantly, and they have a lot of questions. Thanks, Professor Fonseca, for joining us. And thank you, everyone. Hope you are, for our country, the best. Thank you.
Thank you.
Thank you a lot. Thank you a lot. Thank you, our Professor Vivian Fonseca, for this elegant presentation. Thank you, Professor Ibrahim, for the great moderation. Shortly, sorry, Professor Fonseca, I will talk in Arabic a bit.
Okay, I will say goodbye. Thank you very much.
Goodbye.
Thank you for your goodbye, Doctor. Thank you a lot. شكرا لحضراتكم وشكرا لحضوركم معانا. انا مينا امجد، انا برودكت مانجر مسؤول عن الميليتوفيكس ميت. احب بس اخد حضراتكم في تور سريعه اتكلم على البنفيتس اوف ميليتوفيكس. ميليتوفيكس and Mellitofix plain بيريديوس ال HbA1c من بيز لاين اعلى من 10 by 3.7 and Mellitofix met by 4.57. also ده بيأثر كمان يا دكتور ان بيحصل البيشنت اللي حضراتكم بتدي لهم الامباجليفلوزن بيحصل ريدكشن في البادي ويت by 4.5 كيلو جرام بلس ان بيحصل ريدكشن في البلاد بريشر by 6.1 ملم mercury which is reflected by 14% على 3 point MACE. In conclusion احنا نحب نقول حاليا بقى معانا الفول بورتفوليو اوف الامباجليفلوزن ميليتوفيكس بلين متوفر حاليا السوق ال 10 وال 25 ومتوفر حاليا الميليتوفيكس ميت ال 5000 وال 12500 وال 12500. ال 10 وال 25 متوفرين. ال 10 متوفر ب 228.75 229 جنيه وال 25 البلين متوفر ب 297. وكذلك التركيزات مع الميتفورمين الكومباينيشن متوفر بالفري كونسنتريشن ال 5000 12500 و 12500. نبتدي ال 5000 ب 131 جنيه وربع ال 30 قرص. الميليتوفيكس مات ال 12500 ب 153 جنيه ونص. واخيرا الميليتوفيكس مات ال 12 ونص على 1000 ب 171 جنيه. ايفا فارما بتوفر لحضراتكم الامباجليفلوزن الميليتوفيكس سواء البلين او الكومباينيشن بالفول فليدج اوف كونسنتريشن لحضرتك حابب تدي ل 10 او ال 25 سواء البلين وهو حاليا متوفر في جميع الصيدليات وكذلك الكومباينيشن فورم. ثانك يو لحضراتكم. ثانك يو لحضور حضراتكم. Thank you Professor Ibrahim for this moderation. Thank you a lot. There is a small survey حضراتكم ممكن بعد ما تقفلوا هتلاقوه على مونك survey. It is about 3 questions. Thank you for you all. And you're most welcome to also upcoming meetings with Eva Pharma. Thank you a lot.
شكرا يا مينا. شكرا يا مينا بالتوفيق.
Thank you.
كل سنه وانتم طيبين وان شاء الله المره الجايه نبقى اورينا كلنا مع بعض باذن الله ان شاء الله.
ان شاء الله.
اوكي.
ان شاء الله.
سلام يا مينا. سلام دكتور رياض. باي باي.
شكرا يا دكتور مينا وشكرا لكل الحضور. أتمنى إن الأغلبية يقدروا يردوا على ال3 أسئلة اللي موجودة في السيرفي. شكرا جميعا.